This week on the BackTable podcast.
It's important to look for minimally invasive options, but at the same time, please make sure that you do due diligence and due homework in terms of what fits best for you. One size does not fit all. So PAE is a good option, I would say, for 80 to 85% of patients, which is a large cohort of population out there. But when your interventional radiologist or your urologist tells you that PAE, especially you're an interventional radiologist, tells you that PAE is not a good option for you, then it is not a good option for you.
Yep.
So do proper homework and do what's best for you.
First, a brief word from our sponsors.
Less is more. Discover the MVP microvascular plug system, the one-device solution for peripheral embolization. Learn more at medtronic.com/MVP.
RADPAD was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the BackTable podcast. Now, back to the episode.
This is Michael Barraza returning as your host. I'm joined today by Dr. Shivank Bhatia from the University of Miami, and we're going to be talking about the long-term viability of prostatic artery embolization, or PAE, for the treatment of BPH with lower urinary tract symptoms. Dr. Bhatia, thank you for joining us.
Thank you so much for having me. This is a great opportunity.
We are honored to have you on and to hear a bit about your incredible experience with PAE, which has got to be one of the most robust in the United States, if not the world. Before we get into that, I wanted to talk with you a little bit. You know, a lot of our listeners are trainees, and you guys have a really great program in Miami, and I was hoping you could tell our listeners a little bit about what your department and program are like at University of Miami.
Oh, thank you. Thank you for asking that. So we have a very, very busy department and a very robust interventional radiology program, which is really kind of built on the model of service lines. So we have 5 different service lines: the men's health, women's health, interventional oncology, vascular diseases, and musculoskeletal spine. And we actually encourage all our faculty to really be experts at what they do. So everybody picks like 1 or 2 service lines. Just in a global picture, we do around 20,000 plus procedures annually. So it's definitely extremely busy program. And, you know, most of the what we call as category 3 cases, which are the high-end cases, what we all like to do is all the interventional oncology, ablations, Y90s, TAs, prostate embolization, fibroid embolization. All those things are like somewhere between 100 to 300 to 400 procedures per year for each category.
Wow. Do you have residents and fellows, or how does it work?
Oh, yes. We have a large number. We have a very big IRDR program. We have independent ESIR. So at any point of time, we have a very, very large number of residents and fellows who are training with us.
That's great. Good opportunity for them, in particular, getting exposure to prostatic artery embolization. You have amassed an incredible number of cases. And you told me earlier, I mean, how many of these have you done at this point?
My personal experience as a single operator is over 1,800 procedures now.
Incredible. And, you know, a lot of what we're going to talk about today is you've published a very important recent study looking at kind of the long-term outcomes from PAE. And I want to spend most of our time talking about that. But what I wanted to hear first is, you know, because it seems to be a little different at most places, what does PAE look like at the University of Miami?
Sure. I think what you're asking is, how did we get here?
Yes.
You know, like this has been a journey. It's personally speaking, I have 2 kids, and this has been like my 3rd kid. That's how like, you know, my career has been since 2012. I have spent, I would say, at least over 10,000 hours dedicated to PAE, and you know, building this program has required lot of dedication, but I would say more importantly, a lot of collaboration, a lot of support from our Department of Urology and a lot of urologists in the community. The leadership, the chairman of Department of Urology, Dr. Parekh, has been very supportive. So it's really without that collaboration, without that multidisciplinary support, this would not have been feasible. So going back in time, 2011 SIR is when the first time we all heard about 15 patient experience from Portugal, and or maybe it was 14 or 16 patients, but it was a standing room, and I was like almost outside the room, and I was thinking like, this is what I want to do. This sounds great, and this is where I want to build my career. So after that, I got involved with the PAE versus TURP, a prospective, randomized, multi-center study we had two sites, Miami VA and University of Miami. And we ended up actually enrolling the largest number of patients in that study. And before we started enrollment, it would be a remiss to not mention Dr. Francisco Carnevale, whom I went down to Brazil to get trained.
Wow.
Back in 2012. And at the same time, I was applying for SIR grant to study the effect of PA in setting of prostate cancer. This is all very, very early days. And, from 2011 till 2012, I kept knocking urology clinics and urology doors almost like every day, every other day, to the point that they really got fed up with me. and a couple of people, like really urologists, told me like, if we have a patient, we'll get back to you. Please stop coming to our clinic. But no, definitely I was very, very, very persistent. I think it was the key was to do this in a right fashion. Key was to do this in a setting of clinical trial and make sure that there is comfort. There is it will take time, but there will be adoption. And when there is adoption, then it just picks up and the volumes pick up in parallel, tremendously. And again, at that time, Dr. Parekh and the urology department did support me tremendously. There were also, I took the opportunities to go in like local community journal clubs and present this like 15 patient, 20 patient data from whatever it was worth. But trust me, it does help tremendously because, there are so many patients out there who can really benefit from this, larger glands, urinary retention, non-surgical candidates, hematuria. This is how you will start your practice. We started on multi-front. We were doing clinical trials, PAE versus TURP, two sides. We were treating hematuria. We were treating acute urinary retention, larger glands. And meanwhile, we also got SIR funding to study this in setting of prostate cancer. And I always say this, that the best way to convince a urologist is really to convince one urologist in that group and let him convince the rest of his colleagues. And once they see the real life impact of this procedure, once they see the outcomes, they really believe in it and they will support your practice. But the key is to do this in a right way. And I have to mention this because I tell every graduation, I use this one line that guys, residents, when you're graduating, please be a clinician, not a proceduralist. Okay, learn everything about the pathology. And that's why I have limited my career. Though I've done everything, but I've done Y90s and ablations and this, but then I just focused on one or two things because that's the only way you can become more of a clinician. You can take care of your patients longitudinally.
Absolutely. And you've taken it very far. So you've told me a bit about how we got where we are. What does it look like now?
Yes. So, from 2012 to 2015, it was still more of like a building phase. And then 2016 FDA approval came through, and then our numbers just started kind of going up like 100, 150, 200, 250, 300. So right now we are somewhere between 300 to 400 cases per year.
Wow. And you're I assume the primary operator for these?
Yes. So it's me and one of my colleagues. I would say I do most of these cases, especially the elective cases. And then my colleague, Dr. Kabli, he does many of like hematuria, acute urinary retention, and he also treats BPH. And we have a couple of younger faculty whom we are also training, and they are also offering this procedure now. So
that's great.
Yes.
Great
absolutely.
Experience for young faculty getting to see.
Absolutely. We are here to help and we are here to build, and it's really that collaborative environment.
Well, after over a decade of experience with this, where are most of your patients coming from now?
That's a great question. And, I've done a deep dive analysis because we like to stay on top of our referral base. And, it's really a mix of University of Miami urologists, community-based urologists, patients, referring patients, word of mouth, online, social media. It's though we do not do any active marketing, but just our online presence, just like just before we started the podcast, the article 1075 patient, it's an open access. Like people are walking into office with this article and I'm sure they'll listen to this podcast. And, so it's really not one particular kind of source, which I can say that, okay, all my patients are just coming from this group of urologists. It's so kind of diverse, and I think it's very important to keep it diverse.
I think efforts like yours, making this open access, has really resulted in a much more knowledgeable patient population.
Absolutely.
And when I first began doing it, no one had ever heard of it, and I even had to tell the urologist about it. Whereas now, honestly, the majority of the patients that I treat come in already having knowledge of it. Some of them come in asking for it. Some, just look us up directly, having read about it or heard about it or something like that. And that's a huge change.
Yes, it is. It is. And honestly, when I look back, all my patients, it's a true honor when you are able to help your own colleagues. So I used to actually keep a track of how many physicians I'm treating.
Yeah.
And I read that number actually crossed 200, that I treated over 200 physicians, and then I stopped keeping track of it. But just it goes without saying that there is, physicians sending their colleagues and physicians. I actually get referrals from non-urology physicians as well, like interventional cardiologists, even ophthalmologists, people who are like, they are dealing with this alpha blockers and some of the side effects, like, in their eyes and this, and they're like, go to Shivank, get your prostate treated, so you don't need this alpha blocker. So, and obviously primary care physicians. But last I looked at, it was around 85 to 90 urologists who refer patients to us.
And, treating physicians, how you know it works. I can't remember if it was Dave Johnson or Don Garbutt who told me he's treated several urologists.
Oh, yes, me too. So I've treated some senior urologist families. So yeah, that goes a long way.
So now, you're an expert, obviously, at this. And when these patients are either referred to you or self-referred, what all do you want to have in terms of workup, aside from, basic symptoms? One of the things I learned, I don't know if this is how you're doing it now from your paper, is that most of these were getting an ultrasound as part of the workup.
Yes. So no, actually, most of my patients get an MRI.
Okay.
Yes. So we do like to get MRI, and I'll touch upon that in a second. But I think there are a couple of important things here when it comes to workup. We have a very, very strong, methodical system in terms of how we do these workups.
That's great.
And the way we built it, and I still remember before enrolling my first patient in PAE versus TURP study way back in 2013, I was in hospital till late night setting up these protocols. And why I think it's extremely important for younger IRs to understand and learn that if I did not extrapolate what I was collecting for the setting or purpose of clinical trials, all the parameters, and then use those same parameters in my day-to-day clinical practice, I would not have this robust data.
Okay.
Of 1,075 patient, 5 years follow-up. There is no way you can have all that data with post-void residual and prostate size and PSA and obviously IPSS score and IIEF score and all those things. And we'll touch upon some of those things once we share screen. But, it's extremely important to set up those protocols very, very early on in the practice and then always think 5 years ahead. I always like to use the term future back because, you're looking ahead and then what you're going to do today and how it's going to translate 5-10 years from now in terms of how it's going to look on the print.
Yeah. Okay.
So we do, objective and subjective assessment. Uh-huh. So subjective assessment is patient symptom scores, which is the IPSS score. Actually, let me share the screen because I think the right time to have some of these things. In terms of assessment, we do subjective assessment and objective assessment in terms of the prostate size measurement and the PSA and the post-void residual. But when it comes to the patient symptom score, this is the IPSS score, which is kind of like the holy grail of measurement of lower urinary tract symptoms. And this is measured on a scale of 1 to 35, with 1 to 7 being mild, 8 to 9 being moderate, 20 to 35 being severe. And most of the patients will come to us somewhere between 20 to 35, which is severe symptoms. But most of the clinical trials will allow treatment, or even in day-to-day clinical practice, it will allow or recommend treatment for IPSS over 13, which is what we use in our clinical practice, which is mid-moderate. So there are 7 symptoms here: incomplete emptying, frequency, intermittency, urgency, weak stream, straining, nocturia, and they are graded on a scale from 0 to 5. And then the total is graded, and the total is added up, and then you come up with mild, moderate, or severe symptoms. Now, when it comes to quality of life, that goes almost hand in hand, where 0 is delighted, 1 is pleased, which is what your goal is. Most patients will come to us with a quality of life between 4 to 6, which is mostly dissatisfied, unhappy, or terrible. We also measure what is called SHIM score, or IIEF 15 or IIEF 5 score, which is to determine what level of dysfunction or function they have. 1 to 7 is severe erectile dysfunction, while 17 to 21 is mild erectile dysfunction. And we will, when we look at our data, we'll see that PAE actually does not impact erectile function in a negative fashion. So, as I mentioned, apart from these 3 symptom scores, we also do an MRI in most of our patients to look for not only the prostate size, the overall architecture of the prostate, the nodularity of the prostate. We also see the size of the median lobe, which is the prostate growth into the urinary bladder, and see how much that growth is. In my personal experience, I limit like 3 centimeter is the upper limit where I would offer treatment. Anything more than 3 centimeters of median lobe, I will not recommend PAE. The other important thing I look at on MRI is the transitional zone to peripheral zone ratio. If the prostate is more towards like smaller size and it's not transitional zone dominant or central zone dominant, which means it's a small transitional zone and a big peripheral zone, I do not like to offer treatment or PAE to those patients. And last but not the least, I always say, again, to my residents, and I've trained like literally over like 450 interventional radiologists, I always like to tell everybody that your ideal index patient for PAE is relatively larger glands, but more importantly, healthy bladder. So if one take-home point from this podcast I can give to listeners is PAE is not a good alternative for patients who have a compromised bladder. And that compromised bladder, you can see on MRI when there is a thinning of bladder wall and more than 500 cc of post-void residual with formation of diverticuli, which means that the underlying bladder function is compromised, and I do not offer PAE to that subgroup of patients. And then we also do the PSA and the post-void residual. The other important subgroup of patients which I like to really kind of like stay away from or treat them very cautiously is patients who have recurrent urinary tract infections, and especially if they have an active UTI. So that's our overall workup.
And then, after you get them scheduled, I noticed from your paper, you do the vast majority of your cases from radial access. Is that correct?
That is correct. Yeah, it's 80% radial access, 20% femoral access. But that was even after I switched to radial in 2016. So I would say right now it's like 90% radial, 10% femoral.
Okay. Another interesting thing, and reading your paper, you always have to consider that these patients were accumulated while the procedure itself was evolving. And so, some of the patients got embolized with 100 or 300 micron particles, some with 300 or 500. I'm curious what you use now.
I use 300 to 500 mainly, I would say, for most of my patients, 300 to 500. It really is like a perfect kind of like balance between the post-procedure recovery and the long-term outcomes.
I also noticed that once you got access to the prostatic artery before embolizing, your paper, I think you said you used either 100 or 150 microns of nitroglycerin before embolizing. Is that still the same today?
Yes, it is absolutely same today. I think one important point again for young IRs who are listening is the size of the microcatheter is extremely important. I do all the procedures with 2.1 French or less size microcatheters. And as soon as I get in the prostatic artery and I know that, okay, I'm in a good spot, I give nitroglycerin and then my embolic mixture, which is, I use Embospheres 300 to 500 mixed to 20 cc diluted volume. The time between me getting into the prostatic artery to starting embolization, I like to keep it as minimum as I can.
Okay, understood. And I forgot to ask, everybody has his or her own way of identifying the prostatic artery. How do you do your initial imaging, assuming you don't, I didn't hear you say you did a CTA before or cone beam CTA on the table.
No.
What is your method for finding the prostatic artery?
In fact, none of those. No CTA, no cone beam CTA on the table, no MRA. It's really a quick DSA.
Yeah.
And many times it's just store fluoro. You really kind of see for larger glands, I'm just storing the fluoro and I know exactly that this is prostatic artery. But that I think I would say after like 1,000 patients, I started doing that. But I would do a very, very quick, 1 frame, 2 frame DSA, which will show me at like 30 to 45 degrees ipsilateral oblique. And that will show me the prostatic artery, the origin. And then once I get into the prostatic artery, I will do another DSA. Now, if I do not see any potential non-target, no collaterals, then I just start embolizing. I actually do not do cone beam CT even then, but I do cone beam CT at end of embolization now.
Okay, I see. But that's actually, you do cone beam CT without contrast injection, really to look at the gland, right?
That's correct.
All right, cool. And then another question I had, because everybody's regimen is different. What do you send patients home with?
Oh, yes, that's a great question. So I really haven't changed much. I prefer non-steroidal anti-inflammatory. We did start giving Tylenol number 3. I think that some patients need that. And what has changed, I would say, from like first 500 patients till now is we want to give everything they will need for 7 days. So we don't get like these weekend calls because we do so many, procedures every week that we want to make sure that they are covered. But all these patients, I think the most important thing I give them is my cell phone. They can reach out to me if anything is not going well, and we give them a lot of discharge instructions and everything. But in terms of medications is non-steroidal and anti-inflammatory combined with Tylenol 3. We use, if we are not able to give either or, then we do give a Medrol dose pack. We give either a pyridium, which is phenazopyridine, or we give Uribel. We have started to use Uribel a little bit more than pyridium nowadays. We do give antibiotics for 5 days, depending on, again, allergies or not. It's usually Keflex or Cipro. And then we give Nexium and we give Colace to avoid constipation. So all the post-procedure potential things they can have, like pain, like post-embolization syndrome, constipation, low-grade fever, all the inflammatory symptoms, significant burning, and bladder spasms. For that, we give oxybutynin. So we basically target all the medications for each and every potential symptom they can have.
And to my next question, and we'll get into this more when we talk about your article, but what does the follow-up process look like at University of Miami?
Sure. Yeah. So I think, again, that's really what I was trying to give the message that, you have to have a robust follow-up protocol to have this strong long-term data. And for us, the follow-up right now is at 1 month, 3 months, 6 months, 12 months, and then 24, 36, 48, 60-month mark. Even for patients who are just part of routine clinical practice, what has really, really helped is telehealth, especially after COVID, because all these patients do not have to really kind of like show up to clinic to fill all these forms. Before, what we used to do before telehealth, we used to give copies of all these forms and label those as 1 month, 3 months, 6 months, and just tell the patients to send these back to us via mail. And we used to call them if they did not want to come in person. But now with telehealth, and we have right now we have 15 nurse practitioners, and I cannot even imagine doing this without strong support of our nurse practitioners. And they pretty much run most of the follow-up clinics. So 1 month mark, 6 months, and most of the other marks are done by them. I see patients at 3 months and 12 months myself.
Let's shift gears and talk about the article that your group recently published. And for our listeners, Dr. Bhatia and his group have made this open access, so this is available to anyone. But let's take a look at that paper and what you guys studied and what we learned.
Sure, thank you. So this study is a single center retrospective experience, IRB approved, of 1,075 patients treated with prostatic artery embolization for lower urinary tract symptoms or for urinary retention, which is like people are not able to void at all and they have an indwelling catheter, with short, mid, and long-term follow-up up to 5 years.
And this is single center, right?
This is single center and single operator.
Yeah.
So this is definitely the largest longitudinal single center study ever published in United States, and I would say probably largest in the world, because 1,072 patients was from Portugal, but they have now a follow-up which is I think around 1,500 plus patients. So just a little bit of background here in terms of our patient population. Lower urinary tract symptoms, which is based on the IPSS score we looked at, 917 patients were treated for lower urinary tract symptoms, and 158 patients were treated for acute urinary retention, which is patients having indwelling catheter. And the duration of the study was 10 years from January 2014, July 2023, with follow-up at 1 to 3 months, 6 to 12 months, 24, 36, 48, 60 months. The mean age is 70 years in our series, and the prostate size of 107 grams.
It's big.
Yes. And we did a sub-analysis of more than 80 versus less than 80 grams, which we will also discuss.
Yeah.
And the mean IPSS score, which is in severe category, was 23. Quality of life, which is 5, which means mostly unsatisfied or unhappy. The SHIM score, which is the erectile function score, is 17 at baseline. Post-void residual, 110 cc, and PSA, which most patients do worry a lot about the PSA, was 4.7 at baseline. So this is the baseline parameters of our study. And some technical aspect, the mean procedure time 67 minutes. And this is where I have to go back and comment on, as the procedure evolved, as my experience evolved, the procedure time did go down significantly. Before it was somewhere around 90 to 120 minutes, and now it's more like 40 minutes or sometimes even 30 minutes. Fluoroscopy time, because all these procedures are done under X-ray, with live fluoroscopy is 32 minutes with around 2 gray of radiation dose, and 890 patients, which is 80% done through radial access, and rest of the patients, 183, were done through femoral access. And bilateral embolization, which is what we call technical success, is 96.8% in our series, while bilateral embolization was in 1,040 or 96.8% of patients, and unilateral embolization in 35 or 3.2% of patients. So one important thing I do want to highlight is that PAE can be safely done in patients who already had prior transurethral surgical procedures. So 12% of our patients, which is a very large number, 130 patients, already had prior surgical intervention, be it a TURP or TUNA or TUMT or Urolift or PVP, which is green light laser, and some of them actually had a prior PAE as well. So 12% of patients had prior intervention for BPH, and when we look at our reintervention rate, we will see that 15% of patients actually did go ahead and get another treatment after PAE. So I like to tell this to my patient: BPH is a progressive condition, and you have these different options, starting with lifestyle modifications to medical management, which is taking the medications, oral medications, to minimally invasive options, which are called MIST, minimally invasive surgical therapies like Urolift or Resume. PAE is actually also a minimally invasive therapy. then the invasive surgical therapy like for green light laser or prostatectomy. The biggest point I can drive across is with PAE, you are getting outcomes similar to invasive surgical therapy without taking those risks which come with the surgical therapies. So what risks patients are worried about when they look at the surgical options or more invasive surgical options? It really all boils down to, the sexual side effects and the risk of leakage and risk of bleeding and hospitalization and need for catheter. So risk for bleeding, hospitalization, and need for catheter are more of like short-term complications or side effects, which most patients are worried about. And PAE does not have any of those, but those are common with TURP or green light or HOLEP. And then risk of leakage or incontinence, which is, people have to wear a diaper after the procedure. Again, PAE does not have that risk. It is 2 to 3% risk with the invasive surgical therapies like TURP and green light. And same for risk of sexual side effects, which is extremely important for patients, which is risk of erectile dysfunction or retrograde ejaculation. So risk of retrograde ejaculation is extremely high with surgical therapies like TURP and green light laser. And it's nearly non-existent with prostatic artery embolization. And same with risk of erectile dysfunction. It really is almost non-existent or in a very small group of patients with PAE. Do you have any questions?
Not yet. No.
Okay. So let's look at our results. What did we find when we evaluated, over 1,000 patients at different time intervals, from baseline to 1 to 3 months to 6 to 12, 24, 36, and 48 to 60 months. There was a significant improvement in the IPSS score or the prostate symptom score from a baseline score of 23 down to 7 at 1 to 3 months, down to 6 at 6 to 12 months, and 7 and 9 at 24 and 48 months respectively. Now, what does that translate into is 74% reduction in the symptom score at 6 to 12 months and 70% improvement or reduction in the IPSS score at around 3 months and 24 months. And what this tells us is not only there is a tremendous improvement in the IPSS score at 3 months, 12 months, 36 months, and 60 months, but it's a sustained improvement. It does sustain for a long period of time.
It's sustained and it's comparable to what these patients would get from a more invasive surgical intervention.
Absolutely. That's an extremely important point, that if we look at the literature for TURP or green light laser, these are the numbers you will see. You will see the baseline between 22 to 25, and you will see at around 3 months, 6 months, and 12 months, you'll see around IPSS score of 6 and around 70% improvement in the symptom score. So if you get 70% improvement in the symptom score, you're really getting the maximum possible improvement. And that's what PAE can offer with a very good safety profile and an excellent efficacy profile, which is sustained over long term. Now, how does this compare to other minimally invasive therapies like Resume or Urolift? So there you will get more closer to like 50% improvement in the symptom score, not 70% improvement in the symptom score. How about quality of life? So as I mentioned before, quality of life goes hand in hand with the improvement in the IPSS score. So in our series, the baseline quality of life was 5. And at 3 months, 12 months, 36 months, and 60 months, it was at either 1 or 2, which is around 70 to 80% improvement in quality of life at different time intervals, but again, sustained for long term up to 5 years. Extremely important point in terms of IIEF 5 score or SHIM score or erectile function score, whatever you want to call it. SHIM is Sexual Health Inventory in Men, is the form for SHIM. And what our data showed is baseline SHIM score of 17 at 3 months, 12 months, 36 months, 60 months. It actually improved from 17 to 19 or 18. So I get this question all the time from patients, from even urology colleagues. Why do we think there is an improvement in the erectile function score in our cohort? And this is not only in our cohort. This has been shown in meta-analysis of IIEF data, in many, many large series. And the key to understand is that it's twofold. Number one is, first of all, there is no reason for PAE to have a worsening effect on erectile function. The second important thing is that many patients in our series is close to 70% are able to stop the medications they are taking, the alpha blockers or the 5-alpha reductase inhibitors. And those medications do have a negative effect on the erectile function. So they are able to stop those medications. And number three is more of an hypothesis that the prostate is surrounded by this neurovascular bundle, which is really responsible for erectile function. And by reducing the size of the prostate, by reducing the overall, I would say, the hardness of the prostate, make it much more softer, it does relieve this pressure on the neurovascular bundle around the prostate, which is another potential mechanism of improvement in the IIEF score. Again, the improvement is not like tremendous, but again, the improvement is there. Another important thing is the prostate volume. So we see in our series, the baseline 104 prostate volume goes down to 72 at 3 months, 75 at 6 to 12 months, around 81 and 80 in long run, which gives us around 32% reduction in prostatic volume at 12 months post-PAE. So many patients ask me, this is a very common question asked by patients. Well, if you say that prostate is going to go from 100 to 70, my prostate is still enlarged. Or think about a patient who has prostate of 150 grams or 200 grams and you say 30% volume reduction, they are still above 100 grams. Isn't that still a very large prostate? The answer is yes. So how does the PAE work then? Well, not only it's very important for people to understand that, we are taking a soccer ball and making it a softball, not a tennis ball. The prostate not only goes down 30%, 25%, 35%, whatever it is in size, but it also becomes much more softer in terms of its consistency. There is, you can have like just 10, 20, 30 grams of areas of necrosis, and that will lead to tremendous reduction in the pressure effect on the urethra. And that's a very, very, very important point I like to explain to my patients. How about in terms of post-void residual? So what is post-void residual? Post-void residual is the amount of urine patients are retaining at end of every micturition. So in our series, the baseline PVR or post-void residual was 104 cc, and at 3 months it went down to 47, and it kept improving 6 to 12 months at 33, but it stabilized in this range between 40 to 50 cc, which gives us around 68% or 60% decrease in post-void residual at different timelines, which is again very, very comparable to many of the surgical therapies. How about PSA? PSA is a prostate-specific antigen, which is a blood test which patients get done almost every year, and then there is a free PSA and total PSA and ratio. And so many patients do worry significantly about sudden jump in PSA, high PSA. But again, an important thing for patients to know is that high PSA is not indicative of prostate cancer. High PSA can be just due to an enlarged prostate. And PSA is a function of increase in the number of prostatic cells. And yes, sometimes when there is a sudden increase in the PSA, then they do worry with a good reason if they have to worry about prostate cancer. Having said that, the combination of PSA with a negative MRI, and that's the reason we actually get MRI on all our patients, is a very, very, very safe parameter to rule out prostatic cancer. So patients who have, some elevation in PSA, but a normal MRI, no lesions on MRI, they actually do not have to worry about prostatic cancer or prostate cancer in big scheme of things. But if they do have a PIRADS 3 or a 4 lesion, with PIRADS 3 we usually follow up, but if they have a PIRADS 4 or a PIRADS 5 lesion, which is indicative of potentially of prostate cancer, or it's concerning for prostate cancer, we send those patients back to our urology colleagues for targeted biopsy. And there is an additional test which is called 4K score, like a 4K high definition, number 4. and K as in kite. 4K score, which is a simple blood test, which gives patients a risk assessment of lifetime risk of an aggressive cancer. So combination of these three things with the PSA, with the 4K score, and if needed, a targeted MRI ultrasound fusion biopsy. All these three things is standard in our day-to-day clinical practice as needed to rule out prostatic cancer. And so patients can move ahead with getting BPH treated without worrying about the prostate cancer. So what we found in our series is PSA went down in our series by around 50% at 12 months and most of the other timelines where TURP or HOLEP will give around 70 to 80% or up to 90% reduction in the PSA. So how about the retention subgroup? So what is retention? As I explained before, the patients, they're just not able to urinate at all, and now they have an indwelling catheter. So we prioritize how we triage patients in terms of somebody who comes with urinary retention versus somebody who comes with moderate to severe lower urinary tract symptoms, or patients presenting with hematuria. So patients presenting with hematuria get like the top priority, and the second one is patients with retention. And this is the subgroup where sometimes we will even skip doing an MRI because they just want their catheter out. They are suffering, they have an indwelling catheter, and there is also this like misnomer or a concept sometimes where patients who have acute urinary retention with very large prostate, now we are talking about 200, 300, 400 grams, and if PAE will not be effective, it's on the contrary, PAE works extremely well irrespective of the size of the gland as long as it's a large prostate. So as you can see now,
these are my favorite patients to treat, the catheter dependent.
Absolutely. So the median baseline prostate volume in this group is 120 grams. And I have treated patients with 250, 300, 400. The largest prostate size I've treated is 600 grams.
In my practice, I've never even seen over maybe 120, 150.
Wow.
It's incredible. I can't even fathom that.
Yes, no, that's something which we actually are doing. We actually completed a study, prospective study at this point to compare PAE versus HOLEP, which I will touch upon more towards end of our presentation.
God.
That's a late breaking abstract for SIR, and we presented some early data at CERSI.
Can't wait to see those arteries.
Yeah. So when it comes to this subgroup of patients with urinary retention, the only thing you have to worry about is infection. Make sure they don't have active infection when you are treating them. Make sure they don't have multiple episodes of infection. But how do these patients end up with retention? Many patients will go for hernia repair or they will go for knee replacement. And this is just really post-anesthesia, they will end up with retention. Or just like, having a good long weekend, 4th of July weekend with some beers and, some alcohol, and they just end up with retention. So many kind of like just day-to-day life events, and they end up with retention, and now they are desperate. And I asked them only one thing: how were your symptoms before you got into retention? And do you have any data around your post-void residual before you got into retention? If they show me that they had like 1,000 cc of post-void residual 1 year before like today, I would not offer PAE. Because at this point, their bladder is completely compromised. But if they are like, no, I had no major problems. I had some moderate symptoms, and my last post-void was like 200 cc or 150 or even up to 300. I will expedite and I will offer treatment like right away. Like literally sometimes we treat people, they come into clinic in the morning and I ask them, are you NPO? And they say yes. And we walk them across the street. They are Medicare and we treat them. So what did we find in this subgroup of patients? 158 patients had urinary retention as primary indication for PAE with baseline prostate volume of 120 grams. So we treated these patients, and initially we were taking catheters out at around 10 days. Now it's around 2 to 3 weeks post-procedure, and then every 2 weeks subsequently. And at 3-month mark is our success or failure.
Got it.
Okay, so median post-void residual in this group at 1 to 3 months went down to just, 50 cc, which is incredible.
Yeah.
and which indicates that they went down just to normal post-void volumes, PVR volumes after PAE, and 94% of patients developed catheter independence at 3 months after PAE. In fact, I just got a text before this podcast from a physician, 93-year-old physician, who just had his voiding trial over the weekend in the ER, because he was just like, I'm done with this.
Yeah.
The catheter came out and he was so happy and so grateful. So, these are some of the most grateful patients. So post-PAE surgical interventions, which means the reintervention rate, which is what everybody wants to know. The patients want to know, the urologists want to know, the AUA wants to know, our own community wants to know that how does the reintervention rate look like in long term? So this is what we found, that this is like a Kaplan-Meier curve for reintervention after PAE and number of years and the reintervention probability. So in our series, 90 patients ended up getting reintervention after PAE at 6-year mark. And most of those patients ended up getting either TURP or a green light laser or laser PVP. And then some patients ended up getting PAE, while larger glands ended up getting prostatectomy. Now, I am more conservative in terms of offering repeat PAE than many other sites or many other practices across the country or across the world, but that's just me. I believe that PAE can be offered again only if there is significant regrowth and it's been 3 to 5 years and there was real early very good response. And now there is recurrence after a long term, which makes sense that now the patients have, significant regrowth of the prostate. But again, I get stuck on the bladder. I like to evaluate if the bladder is still good before offering repeat PAE. That's why you see only 18 patients got repeat PAE in my series.
Okay.
So this is, again, a data which I think many people are interested in terms of a patient perspective from our colleagues as well as urologists, the medication-free rate. And I would say that, again, the only way we can produce and have this data is really kind of robust long-term follow-up. So in our series, close to 65.5 or 66% of patients were medication-free at 1 year. And though you don't see the data here, I don't have it on these slides, but more than 85% of patients were able to reduce the medications. So if they were taking 3 medications, they went down to 1 or 2 medications. But overall, I tell my patients it's around 65 to 70% that you will be medication-free at 1 year and for up to 5 years. So that's the summary of outcomes. So to conclude, IPSS, so this is to show the long-term data on 1,075 patients where IPSS score improved from 23 down to 6, which is severe to mild category in patients with lower urinary tract symptoms, which is very, very similar to patients getting invasive surgical procedures like TURP or green light. Quality of life improved from 5 to 1, which is unhappy to pleased. Very favorable erectile function safety profile. 32% decrease in prostatic volume at 1 year. Almost returned to normal post-void residual volumes in both LUTS and retention cohort. Low reintervention rate, 16% over 5 years. And 60+% BPH medication independence or medication-free rate at 5 years. And 94% urinary catheter independence at 3 months after embolization. Now, one thing I do want to mention is, we don't have that slide here, but it would be important to discuss the side effect profile. And, how many patients actually ended up getting side effects in terms of post-embolization syndrome, in terms of, many other potential side effects after the procedure. And, the important ones in our series of 1,075 patients were a total of 7 patients who ended up getting either severe urosepsis or prostatic sloughing requiring a TURP or a TIA, which is a minor stroke. A combination of these 3 happened in total of 7 patients, not 7 each, in total of 7 patients. Rest of the side effects, which included a lot of burning, urgency, frequency, a lot of discomfort, pain, low-grade fever, what we call as post-embolization syndrome. That was in 30 to 40% of patients. And, urinary tract infection, which is, again, I always caution patients to keep a close eye on any significant chills with fever because, the symptoms of UTI can overlap. That's just the post-embolization syndrome. That was in 3% of patients, and around 2.5% of patients ended up going into urinary retention after PAE. So where do we go from here in terms of future direction? We need longer and increased number of prospective studies. We need prospective comparative studies. In fact, the study which we are doing at our institution right now, we have finished enrollment, is a prospective study comparing PAE versus HOLEP, which is holmium laser, which is gold standard for larger glands. And in one line, I can say that we are going to be able to show non-inferiority of PAE versus an invasive therapy and gold standard therapy like HOLEP in our data, which we hopefully will get it at SIR as a late-breaking abstract. And obviously, there is need for increased awareness amongst the patients, and I really appreciate being here today and being on this podcast, which I'm hoping many patients will hear about and increase the awareness. And hopefully we get increased funding to support more clinical trials. So many studies are ongoing right now across various sites in United States and all over the world. And we look forward to more data from multiple other studies.
Fantastic. That covers just about everything I wanted to go over. Thank you for sharing your time and expertise with us. It's been an honor having you on. Is there anything that we didn't cover that you want to discuss?
I think we did cover everything. I would say that really in terms of really giving one last clear message to really the patients who are going to listen to this podcast is it's important to look for minimally invasive options, but at the same time, please make sure that you do due diligence and do homework in terms of what fits best for you. One size does not fit all. So PAE is a good option, I would say, for 80 to 85% of patients, which is a large cohort of population out there. But when your interventional radiologist or your urologist tells you that PAE, especially you're an interventional radiologist, tells you that PAE is not a good option for you, then it is not a good option for you.
Yep.
So do proper homework and do what's best for you. That's one big message I would like to give to my patient listeners.
Fantastic. Well, thank you again.
Thank you so much for listening. If you haven't already, make sure to subscribe and follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, or Blue Sky. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabine Don,
Michael Barraza,
and Ali Behetti.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again. See you next time.